Welcome back to LaserChat, where laser experts share their tactics and techniques, proving there are more ways to treat most conditions and certainly every patient. Today's experts, Dr. Jay Burns and Dr. Jill Waibel, share their views from both a plastic surgery and a dermatologic perspective.
Okay, I think we're ready for the first case.
Yeah, let's look at it. This is your case, I think.
Yeah, so this is about a 25-year-old with acne scars, and you know this is about the time they start to come into your office.
Right.
And these are in the temple, which is a common area, and these were atrophic. And it's very distressing to a young person who's out there dating, and so I guess I would say, what would you have done for this, Jay?
Well, what I'll do on these cases, let me just tell you what I do in general, but as you know, Jill, what I do is I get on the phone, I call you, and I say, what's your normal? No, I do. On the scarring, I think you've really changed that about how we handle scars. But acne scarring, I think in general, this is the most difficult people that I see, because they have beautiful skin because they have that thick, oily skin, and if it doesn't get acne, they turn into J-Lo. I'll sometimes excise those scars that I don't know that the fractional can do anything with.
Right, those are tough.
Those are tough ice pick scars.
You do punch excisions, or you just get your scalpel?
I typically do a punch if it's small enough, but if I start seeing a little thing, I'll do a little small excision.
Well, you make a really good point, though, because there was new data out about 2 years ago about when you said they don't heal well. They looked at, in China, the study was done, they had like 600 young people they followed over 10 years, and they found that a third of people with mild acne get acne scars. A third of people with moderate acne get acne scars, and only a third with severe acne get acne scars. So I think we've been wrong all along. I think it's the way the person heals, not necessarily the disease. So for this case, I used the Sciton fractional, and I get a lot of patients, I'm sure you do too, that travel from out of town. So the first thing I do is I use the OCT, and what I found is acne scars are much deeper than we thought. So you'll see that divot, it can be 400 or 500 microns in depth.
Right.
So I will get the fractional and do it to that depth, usually 11% density. I'll do 1 or 2 passes, and then my trick here was I used polyalactic acid Sculptra, and I try to throw the kitchen sink at these scars.
Yeah.
And in this case, because I felt like they were mainly boxcar, I topically put on about a cc of the Sculptra. You can also inject,
Right.
and that was actually just one treatment 6 months later.
You did 600 micron, 500 or 600 microns on these acne scars. Now, because of your OCT data, I use it a lot too.
Yeah,
on the
I think
wrinkles.
we're learning.
We're learning, but do you use it on every patient to evaluate the depth, or now that you have the data, that's what I did because it's hard to use. So do you, on all acne scarrings, I go about 500 or 600 microns. Is that what you do?
Well, yes, and actually, in this case, I did more superficial, but now I like to treat to the base of the scar. And no, I don't have time to do it for every patient in real life.
Right.
But when I do it is if I see a case that I'm thinking something's weird here,
Okay.
or if somebody doesn't respond well to the first treatment. And I tell my acne scar people, this is one of the hardest scars we have. It could take anywhere from 2 to 6 treatments. And I do them every 3 months. I'd be curious how often you do it.
Okay.
And I think the temple area is a nice one because it's thin skin, and so when you get that collagen renewal, it responds well. Cheeks are much harder. Hypertrophic chests and backs are even harder.
Right.
But I'm all about compression for the hypertrophic.
Okay, so you also had one other thing. You said 11% once or twice.
2 passes. Yep.
Okay, so is it once or twice? So it's twice. And so what we found when we were doing the fractional work, long time ago, when people were counting the number of holes, we realized that when you overlap 20% twice, it's not 40%.
Right.
It's about 33%.
Right.
So when you do 11% twice, and I said that, at the talk we've given on this topic about this overlap, it's probably 15 to 17%, so instead of 22%, so 11 twice. So I just wanted to make sure they were clear. And the final thing is when you do the PLA, do you do it specifically underneath each one of those depressions, or do you do it globally in the temple?
So it's a good question. I usually do two things with PLLA. I will first subcise because, again, if I can throw one more thing at this scar, so I'll have it, you shake it up, you have to roll it. PLA is hard to work with, and I'll subcise under that area, and I may or may not be injecting. Then I might inject a little, and then I'll also rub on top because we've actually seen it and we've published that the PLA goes down those erbium channels. Right. And again, I say it's fertilizer on top of your garden. So, the Sciton is taking out the bad acne scar. You're stimulating collagen. And what I've seen in my patients, and I bet you've seen it in your cosmetic patients too, is that you're not just stimulating the scar, you're stimulating the whole area. Those cytokines are global.
Right.
So you're getting this, even though you're only treating 17%, 33%, you're getting a global response in that arena.
Right.
And then I put the sculpture on top, and then we see how we do. And some people are great responders, other people need more.
Well, it's a fabulous result, and you know, as long as I get this question sometimes, I prefer the injectable that you're doing right now because it's easy. You can get it out of a syringe, you can predict it, you can repeat it. Yeah. And some people talk about nanofat and all the things that it has all these wonderful humoral factors in there that we don't know for sure about that. So do you ever do that? I don't, but
well, I don't yet, but there's some new stuff coming out that I might. You know, I'm a big stem cell researcher, and you know,
it's promising.
It is promising. I think that the hard thing to understand about fat is the longevity. For some people it's 3 months, and other people it's 10 years, and we really haven't figured that out. So I think our learning curve needs to increase before we do it, because it's a lot to go through to harvest the fat, store the fat, put it in. And again, I still think we have a lot to learn. And they're not true stem cells, they're more progenitor cells. But I do like fat. I will send to my favorite surgeons like you often for deep divots on the leg when I do a burn and trauma patient. You know, if there's a lot of tissue missing, I think fat's important. So
it's a great case. That's a super result.
We're ready for the next one.
So, so this is a lady that came in, and she doesn't have any limitations. She'll let me do surgery or laser or whatever she wants. And so if someone came in like this to you, I was just wondering, there's a lot of people, I get asked all the time, what are my laser settings that I could set this on so I could get some tightening, or what else could I do? And so I wonder how you would answer the question on a lady like this.
Well, again, and I've learned almost all my resurfacing from you as a wonderful plastic surgeon. And it's funny, you know, I tell everybody the first moment of their consult, I agree with you. We've learned when patients come in, they'll say, I don't like my brown spots. What every patient wants to do is look their best. Mm-hmm. So I actually tell people, you're gonna need a combination of surgery, injectables, and laser. Right. And I think as you age, and aging for, we poor women starts in our 20s, for men it's in their 40s, but I think we can do preventative aging. But you know, for someone like her, I would look at her and I agree. I think her skin, you know, I'm seeing pretty droopy eyebrows. Mm-hmm. Her eyes have aged a lot to me. Mm-hmm. She's lost a lot of volume. Mm-hmm. So I would think of personally as a combination of surgery around the eyes with volumization with some hyaluronic acid fillers, and then of course resurfacing. Yeah. I think everyone should resurface, and I think we're having a resurfacing renaissance. So tell us what you did here, because
so what I did is that. You know, I think for the plastic surgeons that might be listening to this, I tell them that the consult, you know, I don't want them to ever get to you, Jill, because if they get to you, they're never coming back to me. So I want to be able to treat them all in jest. But I mean, the point is I say you're going to age with gravity, and that's going to require some surgery. You're going to age with wrinkles that are dynamic lines, and you can either do that surgically in the brow, or you can do neurotoxins. And then you're going to have to treat the canvas itself of the painting, and that's the skin. And finally, I saved the volume. I didn't do any volume. This picture, I didn't do any volume in this part. But so what I did is I did my standard do a high smash facelift and a brow lift just a little bit to get that lateral fullness out. You know, even a blepharoplasty won't get that lateral full. People say, I just want a blepharoplasty, and they do this, and I go, well, that's not what that is. So I did that. We did fractional around the eyes. You know, I think my studies with OCT determined how deep I went with that. And you know, I think when the companies came out, they wanted us to only do 100 or 200 microns on the eyes. But our studies on OCT showed that there's 400 to 900 microns before you get to the orbicularis. And then the orbicularis is anywhere from 300 to 500 microns. So I did a series of about 10 patients, and I showed that I was getting into the orbicularis, but I had to get to 5 to 6 to 7, even sometimes 800 microns deep on the eyelids, which would scare people. But I think that's why I'm getting results like that last, because I'm going full thickness and I'm actually creating a little bit of injury into the orbicularis. So I just tell people that you might be able to get a better result with a smoothing of the lid cheek junction with a more aggressive technique, but that comes with tons of experience. It's the number one cosmetic morbidity that we have on the face is lower eyelids. So if I can do something simple like this, and 85% of my patients say, this is what I want, that shows me somebody's reasonable.
She looks amazing.
Yeah,
I mean,
well,
just around the eyes and her skin, that dewy glow.
So I would say that.
But the brow lift, now how long will the brow lift last?
Well, the brow lift, the things that we do for the muscle. Now also, when we do the brow, we're also, one of the things that I'm doing is I'm going in there and I'm actually addressing the, the areas where the procerus, the frontalis, and I really believe, I tell people if they need Botox or neurotoxin in the next 10 years, I think that's a defeat. Now gravity will occur, and that'll come back. And I tell people, just like with a face, 10 to 12 years is kind of what it typically looks like. And then, but the muscle, I found it very, if you're aggressive, like I am on that muscle, I don't do an endobrow, I do a standard brow lift. But anyway, I think that I also did resurfacing on her and got rid of her upper lip lines. And
which is the best for upper lip lines. And what I love about her, she's natural and she's more beautiful. Yeah. She doesn't just look younger, she looks more beautiful.
Thank you.
So good job, Jay. Okay, the next one is mine, and I think this is a common plastic surgery scars.
It is.
We see them a lot, and these are the only scars that I say probably will get better within a year. I'm a huge fan of early intervention with scars. I will treat them soon if I need to. So this is, I think, a 28-year-old female. She has, I think, a beautiful breast lift and implants, and she comes in 9 to 12 months later and still has the redness, the new telangiectasias. And she loves her breasts, but she doesn't like her scars, and it limits her in clothing and bathing suits. I'm in Miami. So here you go.
And so this is a patient that's already out 9 to 12 months here,
yes.
And it hasn't faded. And we all get that. It's kind of like the bane of our existence. It's why some people hold on to that.
Some do, some don't. Yeah. And I've seen scars 30 years out that don't fade. It's really interesting to see the patient healing differences.
So again, I agree with you totally, and you throw a lot of things at them in these scars. And so the standard thing we do is I would probably treat her with a vascular laser of some kind, either a pulse dye laser or a BBL. It's a great device, and whatever you have would work. And then I also believe, I don't see that that's hypertrophic, so I think of fractional treatment on that would be also helpful. When that red goes away, you never know if it's going to leave you with a hypopigmented scar.
Yeah, it's
and
true.
So if that would have nothing to do with the treatment. But if it did, then again, some of the things you've taught me as well is I would probably do fractional and do the lattice if I needed to get some color back in that. A thing that's not laser or anything, but if all of that fails and you have a hypopigmented scar and you have someone in your city that can do it, and not everybody can do it, but someone that's really great at medical tattooing or microblading can come in and tattoo those scars, and if they're good at it, it's unbelievable. So we can't forget some simple things like that as well.
No, I agree. The only thing I see sometimes with tattooing is over time the color goes wrong. And I think we're at the verge of getting some new technology. There's some micro-coring technologies that can help.
Right.
So what I did with her is basically what you said is, I addressed it with the BBL. And I did that because she had neocollagenosis that's more diffuse, and these weren't telangiectasias, it was sort of diffuse erythema.
Right.
Now, sometimes I will use pulse dye in combination with a BBL. I will also often use the 1470, the Halo, or a thulium, because there's also some hemosiderin in here. Right. We look at this red color and go, it's blood, but sometimes it's the breakdown because it got trapped in the healing process, and that hemosiderin, I call it poop brown, is stuck in there. So I like that infrared, that 1470 wavelength to get that out, the Halo. And then I actually did do a profractional because I believe that you want to remove it and smooth it out so that there won't be that white underneath. And surgical scars, it's usually 2 to 4 treatments. And I tell all the patients it's based on your expectation, and when you look in the mirror and you don't see it anymore, and they're so happy, and it's usually very easy. I won't do profractional until it's a little bit older scar because especially abdominoplasty and breast scars, they're sort of tender scars. So light vascular lasers, early on, first 3 to 6 months, very gentle. I always talk with a surgeon, someone like you, and say, hey, is this okay? But you can do well, and I'm a huge compression person. I have everybody on compression, and most of these are slightly hypertrophic, but she was very
In the first
happy.
6 months, I'll always put some kind of a silicone or compression on there. The other thing I was going to tell you that I didn't mention it, but the 1470 is something I kind of hold in reserve a little bit because I treat vascular with vascular lasers. That just makes sense. But that's a selective photothermolysis effect. But sometimes you can't get all the red out. And that infrared just goes in there, and it's non-selective. But if it heats a core of tissue, it can knock out some of that vascularity. And so I think that for whatever reason, Halo's not built as a vascular laser, but we all know that it will take some vascular, and that's when I use it.
Well, and you know what I'm seeing? I'm starting to use them more and more, the non-ablative genres, the halos on port wine birthmarks. And what I see is I think it helps the healing. And if you create purpura in the skin, you need almost a mechanism to help that heating. So I think, again, we're still learning. It's exciting. And using lasers in combination, whether it's cosmetic, whether it's scars, in my hands, and I think in yours, seem to give you a better result than mono laser alone.
Right. One final word on this. It doesn't have to be the final. I'm not in charge of it. But I just think one thing that's important, we talk about the business aspect of this, and it's difficult. So what I do up front, because if I'm doing a surgery, then who wouldn't want me to treat their scars proactively? But you said, and I agree, that most of the time these scars heal okay.
Yes.
Okay, so does everybody need it? So what I do up front is you can have a scar package. I can't tell you what that is because it ends up being, if I have to treat all those scars just from a practical standpoint, it ends up being a lot of my time from a surgical standpoint. But so what I do for the surgeons out there, I say, we have a scar package. I believe it will help. I believe it will help you, but you're going to have to purchase that because a lot of our patients are just fine with the way they heal surgically. Most of them will take it, but defining that up front is a real practical issue for me.
No, and I think it is a good point because, I live in Miami. There are a lot of patients, and I think talking about scars when you do plastic surgery, plastic surgery is such a blessing, and the results are great, but there is a trade-off, and every once in a while, you might have a bad result. You could have the best surgeon and the best patient and still an infection happens or the patient, something. So talking about scars is important, but I also think it's a miracle that we have lasers that can help them so much.
It is, and it's helped me a lot. I think I'm a decent surgeon, but there's some times where you do a beautiful breast reduction and it's great, and the scars look like I never went to medical school. It's crazy. So you have to have a way to get out of that. And the best surgeons will have bad scars, and if they don't say that, then they're lying. We have to have a way to do it.
It's true, and I actually think, I did a study with L'Oreal once, and we looked at the collagen type 1 and 3 pre and post resurfacing. I think a lot of this has to do with the patient's inherent healing abilities.
I agree.
And how are you going to know that ahead of time? But like I said, I think most scars we can improve upon. I do early intervention for acne scars, burn and trauma scars, keloid scars. The only ones that I wait for are the surgical scars.
Right.
So
wouldn't it be great
if
we have that marker one day?
I think we will. I think it's coming. I think it's coming. All right, next case is yours.
So this is a lady who's a little bit different because she had some laxity, and again, she would let me do whatever I wanted to, but she also had wrinkles on her upper lip, but she also had acne scarring, chronic acne. So she just wanted to look better, and so the reason I made sure, like most of my pictures, I try to have them at least a year out, because if you do anything, if you take an inch of skin here, their acne scars are going to look better for a very short period of time until it relaxes. So this patient came in, what would you do for this patient? I'll tell you what I did.
Well, I agree with you. I think, you've got to find out what's bothering her the most, but it's the laxity, again, she's got good shape, and then the acne scars. So she is I would probably send her for surgery, work on her skin texture I would again go fractional. It looks like she has rolling in boxcar to me.
So what I did is I was telling people that when a patient comes in and they have large pores or acne, historically we treated them with dermabrasion and peels and classic resurfacing, and I just don't think that that's the way we should do that.
That can actually make pores worse because pores get bigger as you go down, and when you resurface big pore patients, as you know.
Right. I tell people if a patient mentions the word pore, do not do a classic resurfacing deep on her because you'll make the pores bigger. Right. So on her, what I did is, again, knowing your laser, what I did is I did, a facelift on her. She didn't have a whole lot of laxity, so I just did kind of a lower which was easier. And then it allows me to resurface her, but I did resurfacing on her upper lip lines, the classic full fill resurfacing, which are better for, I think, deep wrinkles.
Oh, it's the only thing that works.
Yeah, and then on cheek, I did the pro fractional, and for a year out, I think she's great. Now, the one thing I did, again, some of these are, I'm not showing you the filler. I'd like to do that maybe in the future. We ought to do another one of these and show you, because at this point, I think she could come in and you could do, like on her right upper lip, camera left, her right in there. I think you could do some filler or go for that atrophic scar with some more laser specifically for fractional on that, and do what you did with the PLLA in the previous case, or something like that, and then help some of these other scars, but there's no filler on that. But I think she'd
why don't you talk about your passes, because I learned from you, and you did all of that in the surgical setting. You did the facelift same time, upper lip. And I will tell you, the only thing in my hands that works for perioral wrinkles is traditional Sciton erbium done. But why don't you talk about your technique?
So my technique, I call it the island technique. So what happens is that each one of those lines, I treat the ridges and go over. And I start at about 250 microns with 2 passes, 125 each. Now I'm down and I look at it, and if my end point is 2. If the wrinkle goes away, or if I get mid-reticular bleeding.
Right.
And so
which you see is very obvious.
It's very obvious, I think. It's just when papillary bleeding looks like a lot of fine vessels, and when you get down and there's not as much bleeding and they're larger and they're further apart, that's in the reticular dermis. And if you don't have the wrinkle gone away, but you have reticular bleeding, you still got to stop.
Big time out, yeah.
Yeah. So anyway, some of these wrinkles go too deep. So what I worry about some is that if you go over the whole upper lip with just 200 microns at a pass and go to 800 microns, I worry that you're taking away the ability for that lip to help itself. You can only heal from appendages, and if they have poor appendages or thin skin, then you're counting on epithelial migration, and it can only go about a week and you've got to heal that wound in 2 weeks. So I try to treat deeply where I go and try to leave every area that doesn't have a wrinkle, try to leave it as less deep as you can so it can help the other areas. And so I wrote about that in PRS in 2019. So that's what I did to her. And then on the fractional, I treated her with about 700 to 800 microns deep with about 3 passes at 11%. And you might could have gone more than that, but that's what I did.
No, she looks beautiful. And look how the glow of her skin. And that's real.
Yeah, it is real. People used to think it was a lighting technique, but we now know over 20 years.
We see it over and over.
It's new collagen, it's the reflection of the new collagen in there, and it does give them a glow. You see that with Halo a lot as well.
Yeah, and then the other thing that's really emerged is that resurfacing prevents skin cancer. Because there's an inflammatory, you're taking away a lot of that bad skin. So I call it a win-win, your skin health and skin beauty.
Click the subscribe button to ensure that you never miss an episode of LaserChat.